Our speaker grew up in Portland, Oregon. Go Cardinals. Went to Stanford and then University of Oregon Medical School, where he began his first addiction treatment program in 1972 and has run addiction treatment programs of all different stripes since. Was part of the University of Texas Health Science Center at Houston for 21 years, teaching addictions to residents and medical students, as well as having a private practice. So comes to this meeting having experience as a CEO, as a clinician, and as a person out there convincing people to consider the treatment program, which we used to call marketing. I'm not sure what they call it now. Of those things, the one I was best at was program design and being a clinician, and the one I was worst at was being a CEO. I was a terrible CEO and never want to try that again. So for those of you who are CEOs, CFOs, COOs, I am in awe of your ability to maintain your composure. So I'm glad to be here today to talk to you about telemedicine. How many people here are at least familiar with the concept? How many people here, their program or they are actually doing some telemedicine of one kind or another? And how many people here think it's a terrible idea and they never want to touch it? Well, not many. I'm going to show you, if I can, where it's useful and where it's not useful. Let's define telemedicine or telehealth, tele-addiction medicine, telepsychiatry. These are clinical encounters that proceed over video conferencing and the use of an electronic medical record. Full disclosure, I work for a company called JSA Health Telepsychiatry. It's based in Houston, Texas, and our business is providing psychiatry and addiction medicine services via telemedicine, mostly in Texas, also in Louisiana and California, on cruise ships, and soon in China. Here's my plan for today. I'm going to tell you a little bit about telemedicine and show you some research. I'm going to give you some technical information about how it's done. I'm going to give you my personal experience of doing this for the last 6 years. That includes some tips and advice that you won't read in the journals because it comes from me. Then we're going to take some questions. At 3 o'clock, as close to that as I can do it, we're going to connect via our software and through the internet from the hotel to the company, JSA, and talk to the CEO. His name is Avram Fishkin, and he's given us 15 minutes of his time to talk about it. I'm going to take the webcam and turn it around so it faces you. We've got a microphone that my friend Dave is going to move around the audience and let you ask questions of the CEO. So you can ask clinical questions of me, administrative and legal questions of Avram, and then we're going to connect with Will Yancey, who's our director of IT, and you can ask tech questions of him. That's the plan. Telemedicine is very useful for radiology. They've been doing it for a very long time because the radiologist doesn't really have to see the patient, he just has to see the picture. Same with pathology. They need to see the specimen, they don't need to see the patient. Dermatology, they've been using it by taking high-quality photographs of a lesion and transmitting it. Infectious diseases is mostly thinking, doesn't really require seeing the patient very much. And endocrinology the same. Psychiatry, you don't actually touch the patient very much, if at all, and therefore it is amenable to this form of medicine. There are a lot of, however, misconceptions about what you can do and what you can't do. This doctor says open wide. It doesn't work very well for that. But it does work well for psychiatry and, by extension, addiction medicine. The clinical advantages: we can reach clients and programs 24/7 essentially anywhere in the world. My clinics are in West Texas. I've never been to where my clinics are. My clinics are on Tuesday and Wednesdays. Today's Tuesday. This morning I was in my hotel room and I did my clinic in Presidio, Texas, which is 400 miles from anywhere. And it'd be essentially impossible for me to get to Presidio from where I live in Houston. So one advantage is being able to access clients in a remote location very effectively. Safety and security rears its head when every time a patient coughs, every time you read about a violent episode somewhere. I'm seeing patients by telemedicine. It doesn't matter if they have the flu, and it doesn't matter if I do something they don't like, they can't threaten me because I'm not there. Most of the treatment programs that we work with, and the ones that I particularly work with, do not have access to a psychiatrist or an addiction specialist. There simply isn't one. My guess is that where most of you work, there's the availability of a Suboxone prescriber within a short distance. There are no Suboxone prescribers between San Antonio, Texas, and Santa Fe, New Mexico. It's a distance of about 600 miles. I cover an area of West Texas of 20,000 square miles, of which there are no psychiatrists or addiction specialists at all. The other part is time availability. Because of the way our outfit works, we can provide consultation on a 24/7 basis, basically within 20 minutes of a phone call. Now, the satisfaction of the clinicians, that depends on the clinician, but we now have 30 doctors in our group, and they seem pretty satisfied with it. And I'll tell you some more information about why in a little bit. From the administrative point of view, using telemedicine, you only use that service when you actually need it. So you don't have a highly paid specialist sitting around drinking coffee when you would prefer that that person be working. The way our medical liability policy works is that it covers every clinical encounter that we do, so that the facility that we work with is not responsible for the medical liability coverage. Now, I want to talk just a little bit about research. How many of you here have participated in a research project, collecting data, assessing clients? It's maybe 10 people at the most. When I was in private practice for 12 years before I went to the medical school, and I believed that research was mostly a waste of time until I got to the medical school and they said, you will participate in a research project. And then I found out that it was far more difficult than I had imagined. And the two questions that you must identify when you're doing research is, what is the study design, and what is it you're planning to prove or show? And if you cannot answer those questions clearly, then your research is not worthy. And when you look at a research project, a published report, or somebody who gets on a stage and gives a lecture about research, you must ask both those questions. What is your study design, and what was it set up to prove or to show? Now, all the studies in telemedicine are non-inferiority trials. A non-inferiority trial compares an existing treatment with a new treatment and asks, is the new treatment not worse than the existing treatment? That's all it asks. And then the design of the study must show that there are sufficient clients in the study to demonstrate this. So as you look at the 3 or 4 studies I'm going to show you, please pay attention to what it purports to show and what it does show. Now, the first one is about depression treatment. These were outpatient psychiatric treatments. They had 119 patients who were assigned to either face-to-face psychiatry or telemedicine. They had 8 sessions over 6 months. The psychiatrists involved saw patients in both groups. Sometimes they saw the face-to-face patients, and sometimes they saw the telemedicine patients. I'm going to stop here and ask you if you see anything wrong with the study design. How many people here have treated depression? How many feel that 8 sessions over 6 months is ideal? Yes or no? So what do you think about a study that's designed with 8 sessions over 6 months? Yes? Okay, so her comment was it's flawed, but it represents reality. Now, a research project is not meant to represent reality. That is not the purpose of a research study. The purpose of a research study is to find out if something's better or worse. Now, I accept your comment, but we're looking at whether this study will show what it purports to show. You follow me? So, if I want to show that one thing is not worse than the other, what happens when I have only 8 sessions over 6 months? It's going to be easy to show that one is not worse than the other because neither one of them did very much. Do you follow me? If nothing much happened in either group, then one is not worse than the other. That's the issue with a non-inferiority trial. So I'm showing you the research, but the research is not very good. We're going to go on to another study. This was counseling for, and by the way, all these slides are available to you through the Access website. Counseling for PTSD. How would you know if somebody got better from their PTSD? If you're going to treat it, you must know what better looks like, right? If you're going to treat PTSD, you must have an endpoint. This person is better, I know he's better because. Help me out. Specifically? Okay, choose one. Choose one thing that you want to measure. Just one.
Vigilance.
Hypervigilance. He wants to measure hypervigilance. How will you test it? How will you find out if it's better or not?
You'd have to ask the client.
I'm sorry?
You'd have to ask the client.
I still missed it.
Self-assessment.
Self-assessment. Oh, ask the client. I mean, are you less hypervigilant than you used to be? I was thinking maybe you'd say you put him in a room and slam the door and see if he hit the floor. Okay. So let's say we do that, and we see if we put him in a room, we say this is going to be a nice quiet room, we slam the door, and we see if he hits the floor. Is that a measure of whether he's better or worse from his PTSD? Okay, we've measured something, but does that tell you? Now, if you're going to treat something as complex as PTSD, was one measure like that going to be sufficient? I'm saying look at the study design. In this study, they had 48 patients. They gave them either 19 to 21 sessions of an hour each. Here's the data, which you can look at later. Basically, it says there was no difference in the treatment between telemedicine and face-to-face counseling. Does that prove that one is better than the other? What does it prove? Maybe neither one of them works, okay? It proves that one is not worse than the other. So, I know I'm talking about telemedicine, but I'm asking you to look carefully at all research that may be presented to you and see if what it shows is that one thing is not worse than the other, and then ask, did it really show very much? Now, here's a piece of data that is a little bit different. These are the numbers from when we started doing telemedicine at a respite center for psychiatric patients, psychiatric and addiction patients, did a lot of detox there, out in East Texas. And in 2005, there were 476 patients were admitted from the respite center to the hospital, psychiatric hospital, because they could not be managed. 2006, it was 532 patients. That's when we started doing telemedicine. Before that, they didn't have, they had a doctor who came by occasionally. The first year, 449 admissions, then 408, then 293. And when we finally got our act together, 221 admissions. Now, this is a different kind of data. This is what you call outcome data that showed that telemedicine actually did change the number of patients who could not be handled. And believe it or not, we run a respite center, a detox center, where none of the doctors actually go there. There's a nurse, several nurses, techs, support staff, administrator. There is no doctor there. We do it all by telemedicine. Now, if you're going to get started with telemedicine, there's several things you're going to need. One is hardware. Today, the hardware is actually pretty easy. Any new computer. I've got a Logitech 920 video camera with microphone. You need a quiet keyboard because if your keyboard makes a lot of noise, it'll be heard over the microphone. You need you need a support system with a company or group or outfit that knows how to do the tech part, because there's a lot of problems that you may not expect that come up every day from the tech side. For software, you need a video conferencing software that is HIPAA compliant. Just ask a quick question, is Skype HIPAA compliant? Skype is not HIPAA compliant. Gmail is not HIPAA compliant. Gmail Hangouts is not HIPAA compliant. Facebook is not HIPAA compliant. Now, if you're an individual therapist and you have one client that you're seeing by Skype, you'll get away with it. But if you're going to go through a CARP or a Joint Commission survey or a state survey for Medicaid, you're not going to pass if you're using Skype. You need secure software for your electronic record. You need secure fax software. And secure, if you're going to use email, it has to be a secure email, not Hotmail. When you talk to your internet service provider, you need bandwidth, and then you need more bandwidth. Now, do I have it here? Yes. Here's my bandwidth at home. It's not an ad for Xfinity. It's an ad for having bandwidth. My bandwidth comes out to like 125 megabits per second download speed. That's pretty good, by the way, if you're not familiar with that number. The hotel this morning was 5. Here's what it looks like when you don't have enough bandwidth. So we have tremendous bandwidth and I have at home, but the clinic does not. And you have to have it on both ends. So there's a client sitting there. I didn't worry about getting a release because I didn't think you could recognize him. That's a client in that chair. So you must have adequate bandwidth on both ends. So some of our clinical sites, hospital emergency departments, very helpful to the people there. Somebody comes in and they're overdosed, or they're needing detox, or they have a psychiatric problem, or they have a psychiatric problem and an addiction problem. And this is, let's say it's a 40-bed hospital. Are they going to get an addiction specialist or a psychiatrist to show up there at the emergency room? Is that likely to happen? No. So what do the emergency doctors usually do? What do they usually do in that situation? You must have dealt with this. They don't pick up the phone. They pick up a syringe. What do they? Who's gone back to see a client in an emergency room? What'd they get? Something to knock them out. Usually it's Ativan and Haldol. And where did they learn that? They learned that in their internship. Somebody, in their internship, when they were in the emergency department, that's what they did, and so that's what they still do. What kind of counseling do they do for the average patient in the emergency department? None at all, okay. If they had access to you or someone in your program or your medical director, would they use it? Well, that was an interesting question. You can ask our CEO how he convinced people to do it, but in a moment you'll see how many clinical sites we have where he has been able to convince community emergency departments that by using telemedicine they can get better service for their clients. Hospital and treatment center admissions, we do after-hours admissions and weekend admissions for a large number of programs because they simply don't have the staff to cover all those times. My clinics are rural public mental health clinics, but we also do inner city clinics we do one called Search, which is homeless people in Houston. We do the what's called MCOT, Mobile Community Outreach Team in San Antonio, where the social workers go out to under the bridge or places where homeless people are living. They bring an iPad with them, they connect via 4G, and we use telemedicine over an iPad to connect with the clients. We have programs in juvenile justice, in prisons, and on cruise lines. Holland America has 15 ships, and we provide the addiction and psychiatric consultation to cruise ships all over the world. I've done it myself. I help detox people via telemedicine. Anybody been on a cruise? Did you see a lot of drinking anywhere? Yeah. Respite care. Respite means a level of care that's not a psychiatric hospital, but it's also not an outpatient clinic. And it's very useful for detox, and it's useful for people with temporary aberration in their mental health. And we have several respite centers that we cover now where we do it entirely via telemedicine. I mentioned MCOT. One of the hospitals, St. David in Austin, has the video equipment on a little rolling cart, and when they need a psychiatric consultation, they roll it down the ward to the patient's room, and that's how they see the clinician. I want to spend just a moment on this next one, which is what I call high-profile clients. Celebrities, VIPs, professionals, people who don't want to be seen sitting in the waiting room. They're uncomfortable being in a treatment center. That's why they go to the fancy treatment centers in California where there's other special people. I come from a background in addiction treatment that anything that makes you special, different, or better than the other guy impedes your recovery. Whether you're a physician or a celebrity or a sports hero, whatever. My bias, I guess I'll call it that, my bias is to treat every person the same because their addiction is the issue, not their celebrity. I'm not sure if you agree with me or disagree with me, but I do not support specialized treatment for VIPs. However, having said that, a lot of VIPs and celebrities and high-profile people will simply not engage with treatment unless their anonymity is protected. And so this is a compromise which has worked for me. So I am seeing some high-profile folks via telemedicine in the evening or in their office and they don't have to come to the clinic. They can see me over the video and nobody has to know about it. It's also good for them because they don't have to take time to drive across town. Another group of high-profile clients I'm calling the unforgiven. If you saw that movie with Clint Eastwood, these are child molesters, people with deformities, people who weigh 500 pounds, who can't or won't come out. I see the patients from the jail in Pecos County, and they come in leg irons and orange jumpsuits, but they still have a problem and deserve treatment. But how do we get to it? The answer is we get to it through telemedicine. We have a couple of addiction treatment centers where we do the admissions after hours, the detoxification orders. I have written the protocols for detoxification. It's not hard to do. Rounds and discharges. And in my outfit out in West Texas, I was doing weekly in-services and staffings, again, via telemedicine. So since there are not enough addiction specialists and psychiatrists to go around, telemedicine offers you the opportunity to provide services where they would not be otherwise available. Now, advantages for physicians. You can work from your home or your office or just about anywhere. I work from a spare bedroom where I live. You can use pretty much any computer if you put the software on it. I brought my computer with me. I did it from the hotel room this morning. I'll do it tomorrow as well. You can schedule your time a little more efficiently. And a couple of specific things. I'm able to complete the clinical record, the EMR, while I'm seeing the patient because I can type on the computer without interfering in me seeing the patient. I can also wear whatever I want from the waist down because they can't see it. Now, disadvantages, you don't have somebody down the hall that you can go talk to about a client, but we deal with that by using conferencing software between us so we can ask questions of each other. You don't have any personal contact with the patient, so you can't give them a hug or shake their hand. That's a disadvantage. If there's a physical exam that needs to be done, it has to be done by others. We have a nurse at the clinic, and that helps. There is a significant technical learning curve, but that can be overcome. There are continuing technical problems with equipment, and you must have adequate IT. If you don't have tech support and you don't know how to get it, this is not for you. There will be a few clients that want face-to-face and won't accept the telemedicine, but not many. There's a legal issue, that's about licensing, and I'll summarize the Texas licensing statute by saying the practice of medicine occurs where the patient is located, not where the physician is located. So where the patient is, that's the practice of medicine. HIPAA requires that you have a secure environment. I'm sure everybody here's dealt with HIPAA, have they not? Yes? Did you enjoy it? Did you follow the rules? And when you followed the rules, was there a problem with when you went for Joint Commission or something? If you followed the rules, did you have a problem? Okay, we don't have a problem because we have rules. The rules are the patient has to have a secure environment, the door is closed, there's nobody else there, it's not recorded. There's a secure environment for the physician, the door is closed, nobody else is there, it's not recorded. The communication is encrypted in both directions. My statement to the patient is encrypted and his statement to me is encrypted. We have a dedicated server at the office, so it cannot be hacked by anybody. The EMR is also encrypted and secure. So all other HIPAA rules apply. You can't take handwritten notes and leave them around. You can't print out records. The fax machine has to be secure. So you've got a list of these things, you follow the rules, it's not difficult. Here is the consent form for telemedicine consultation. Here's the specific consent form for the meeting I'm about to have with the patient that they sign every time. So here's me. This slide's a little bit old. There's me with the laptop computer with the electronic medical record, and there's the screen. It's got my picture on it right now because you can see the webcam just above it. It's showing a picture of me. So I'm getting started in the morning. Here's what the electronic medical record looks like. So you can see in the corner there's my computer with the EMR, and then over the top of it I can see the client. Or I can set it so that my picture is on half of the screen and the client's on the other half of the screen. Or I can set it so that my picture is way down in the corner, so I can just make sure that I'm in the frame and the patient has most of the screen. Here's one of my social workers at a different clinic, and this is a widescreen monitor, and so I can see the client, and there I am just to make sure that I'm in the frame. I have a new monitor. As you can see, it's a great big one. And on the upper left is the video conferencing software. Below that, I've got Google open if I want to make a search. In the upper right is the fax software. Just below that is Google Translate because I see patients who speak only Spanish, and my Spanish is fair, but it's not great. And then down below is the EMR, and in the upper right-hand corner, upper left-hand corner of that is the video camera control. So I have all this on my desk. Full disclosure, here's what I really look like. My desk is a mess. I'm wearing jeans and socks, and what the patient sees is me with a shirt and tie. So that's, between you and me, it's very convenient. A couple of tips from the trenches. Non-glare glasses. You might think this is a small thing. Here's me with my regular glasses. Here's me with non-glare glasses. Makes a very significant difference in how the patient interacts with you when they can see your eyes and when they can't see your eyes. Remember, there's a disconnect here because they can't touch you, they can't see you, they don't see you in 3 dimensions. But if you have these regular glasses and there's the glare from the monitor and they cannot see your eyes, then it distracts from your ability to connect with the patient. Sounds like a small thing, but it's a significant thing. You need a quiet keyboard. This keyboard that I've got right here, which I use, I'm going to tap on it. Did you hear anything? No. But if you have a clicky keyboard, it really gets in the way. The background. One of our clinicians was a diehard UT fan, had gone to UT, and he had all sorts of UT memorabilia in the wall behind him, hook 'em horns and all that. And some of the patients were from Texas A&M, and they actually filed a formal complaint. So I make a point that the background is not distracting. You have to position yourself appropriately in front of the camera, because if you're not looking at the camera, the patient doesn't see you looking at them. So you don't actually look at the patient on the screen, you look at the camera, and then the patient sees you looking at them. Do you follow me? If you look at the image of the patient, then what the patient sees is you looking somewhere off to the side. Outside noise. Every so often somebody is mowing their lawn outside, and that's very distracting. Okay, increase latencies. Latency is the length of time between the last thing that the patient says and the first thing that you say. Now that sounded pretty difficult, but the fact is, over telemedicine, you don't have all of the nonverbal cues that tell you that somebody's about to talk. When you're having a conversation with somebody in person, they nod their head, they move forward, they open their mouth a little bit, and you know when they're about to talk, but you can't tell that on telemedicine. So if the patient's talking, you have to wait just a little bit longer to make sure that they're finished before you talk. And when you ask a question, you got to wait just a little bit longer to give them a chance to reply. Don't just ask a second question. So if you said, when was your last drink? And they don't respond immediately, it's not because they're hiding something, it's because the telemedicine makes it a little difficult to tell that. You have to exaggerate nonverbal cues. So you do nonverbal cues all the time when you're interviewing somebody. You nod your head, you lean forward, smile a little bit, tilt your head to the side. Over telemedicine, you've got to exaggerate these cues because they can't be seen that well. The same with affect. You have to exaggerate the affect a little bit. If you ordinarily would open your eye, lift your eyelids up, you got to lift them up a little bit extra. If you're going to move your head, you got to move it a little bit extra because it cannot be seen that well. One thing that I do is I sit pretty still, but if I want to emphasize my point, I move forward towards the camera. If you have little tics or habits that you do, brush your nose, fiddle with your glasses, chew on the end of your thumb, these become far more obvious on telemedicine. It's right in front of the patient. So you have to be aware of the little things that you might do, pull your hair back, whatever. It is much more obvious. Complete your clinical note during the interview. It's not hard to do. You're typing out exactly what the patient says. You can nod your head, and you can even look down at the EMR, and that is not distracting. So that's very helpful. In person, you tend to screen out of your consciousness outside noises and distractions like the silent air conditioner or the dog barking in the background. These become extremely obvious in telemedicine. So if you do have a dog, you're going to do something about it because people will hear it and it will be distracting. Disconnect the telephone. If his phone starts to ring, you really can't say, excuse me, pick up the phone and talk to the dry cleaner. You can turn off the sound on the computer, phone's still ringing. So you have to have a way of doing this. Simple thing is, I've got an answering machine, obviously, I'm sure everybody does, but I just disconnect the phone in the room so that it doesn't ring. You've got to learn how to use an alternate internet connection. One day I was about to start clinic. My clinic starts at 8 o'clock. At 7:45, I was dialing in, getting ready, and all of a sudden the internet went out. I called Comcast, and it turns out that a construction crew digging in my neighborhood had cut through the fiber optic cable, and there was going to be no internet for the rest of the day. I took my iPhone, I set it up as a hotspot, I went through 3G, I connected to the computer, and I ran my clinic through my iPhone, and it worked just fine. How many people know how to do that? Okay? It's one of the things you need to learn, is how to get an emergency alternate connection. The bandwidth was unbelievably good. I didn't believe it would work, but it did. The bandwidth was adequate. Amazing. Yeah, Steve Jobs. Staff issues. When I do it, the social worker is in the room all the time. That makes it a little more expensive for the clinic. That's true. However, the social worker can complete a note during the same time that he or she is there with me. It provides us documentation if there's a problem. There have been a couple of times when I was extremely glad that there was somebody there to document that what I said is what I said. The social worker gives you assistance with referrals. If I say, is there a women's shelter we can contact? The social worker knows the answer to that. The patient has a sack full of medications. You can give it to the social worker to read off what they are. I fax things all the time. Pretty much every time I see a patient, I send a copy to the family doctor so they know what we're doing. And I fax information and write a little note and fax it over there. There's a nurse in the clinic to check the vital signs and check for jaundice, etc., but I don't use the nurse very much. Satisfaction and complaints. I just checked with our COO in 2015. There were no complaints at all from facilities, vendors, or the medical board. They do a patient satisfaction. It was about 90%. And most of the people who complained said that they had to wait too long, or the people who were on involuntary status, like at the jail. They were not happy about it. A total of 2 patients refused telemedicine services in the entire year of 2015, of several thousand. I don't know exactly how many contacts we had. Since 2008, 2 programs that started telemedicine have dropped it to return to face-to-face. Currently, as of today, there are 41 clinical service providers and 256 unique sites and facilities that we serve. We have 30 physicians and 1 nurse practitioner. So why would you want to consider telemedicine for your addiction treatment facility or for your addiction treatment program? One would be to extend and expand services. You could reach places where you cannot currently reach. You could fill in gaps in service. Maybe you have difficulty doing admissions on Sunday night. Maybe you need a psychiatric consultation. Maybe you can't find a physician at all to come out and do the evaluations for admission. Perhaps you want to start service at a remote location. You're not sure if it's going to work, so you don't really want to go to the expense of building a new facility, but perhaps you could rent a storefront and do some telemedicine and see how it goes. You might want to treat high-profile clients. You probably already do. This is particularly helpful for aftercare and follow-up with those high-profile clients. You can get expert consultation when you need it. So we have a child psychiatrist, we have forensic psychiatrists, and ordinary plain vanilla psychiatrists, and I'm the addiction expert in our group. And then you only use the consultation when you need it. So I want to show you what things look like, if I can. See if I can make this work. So here is the intranet. So we have an internet and an intranet. And this is the internet site. This is where anybody can go. The intranet is for us, for the team. So, for instance, here's the staff contacts. So these are all the physicians and their connection numbers on the video conferencing. So I wanted to show you that. The fax software. That's what we use for fax software. We use my Gmail. We have a chat line where we don't talk about patients specifically, but it's a good place to complain about how life is mistreating you. I'm going to take some questions, and in about 4 or 5 minutes, I'm going to see if our CEO is available. A little hard to see. Over here, please.
Maybe I missed it. Did you say which video conferencing application you use? Skype doesn't work. I don't think FaceTime would use WebMX? Or which one do you use?
ClearC, it's called. ClearC. But there's a number of them. I think there's a vendor here at the conference that's providing that front end. I can't see. Yeah. David, why don't you just find someone?
Do you cross over? Do you go from state to state, or is this all in Texas?
The practice is where the patient is. So our group started off in Texas, and every one of the doctors is licensed in Texas. We expanded to Louisiana, and only the doctors that are licensed in Louisiana can do it. Same with California. The cruise ships, anybody with a U.S. license can do it. And the same in China. We're going to start doing addiction and psychiatric consultations for expats in China. So basically, you have to be licensed in the state where the patient is at.
Perhaps I missed it earlier, but did you talk about how you're getting reimbursed?
One more time.
Did you talk about how you're getting reimbursed?
Reimbursed. Yes, I can give you the general answer. You can ask Abram more detailed questions. As far as I know, all of these are on contract. Abram has negotiated a contract with the Public Mental Health Agency for my services. And I get paid a flat hourly salary, and then he bills them however much he bills them. I've never asked. I assume he makes a little bit of money on it. For the emergency consultation, there's if you want the consultation within 4 hours, it's a certain amount of money. If you want it within an hour, it's a certain amount. If you want it within 5 minutes, it's a certain amount of money. I don't know what those details are, but I know that he's negotiated these, so we don't actually bill the patient for the service. You bill a facility for the service.
So we're not really dealing generally with insurance companies or third-party payers?
I'm sorry, the sound is too boomy. I can't understand it.
So we're not generally talking about third-party payers or insurance companies?
The outfits are. So the group that I do service in the public mental health clinic, and they bill for my services. So I have to do my record and everything that's appropriate for them to bill, and they do. And they bill private insurance, and they bill Medicaid, Medicare, Champus. They bill all that, and it gets reimbursed as a clinical visit.
Thank you.
Any other questions? Thank you very much.
Okay, let me see now if I can connect. Let me see if I can do this.
We actually have a question here, Terry.
Go ahead.
What about prescriptions for controlled prescriptions?
Did you ask about prescriptions?
Yes.
Yes. The electronic medical record has a prescription module, and I write prescriptions on the electronic medical record. The clinic prints it out on a special prescription paper, hands it to the patient, and they walk away with a prescription. It happens immediately. Controlled substances, Schedule 4 and Schedule 3, we can do that. Schedule 2, like medications for ADHD, have to be a physical prescription, and for that, the clinician writes a physical prescription and puts it in a FedEx envelope and sends it to the clinic. Myself, I don't write any of those, so I'm never bothered by it, so I just have to worry about Schedule 3, which would be buprenorphine, and Schedule 4, which would be, say, Klonopin. Yes, I thought I had this. Are there additional questions? Here is Abram's number. Yes, please.
Is the social worker in the room legally required, or is that just your
I don't
policy?
know if the social worker is legally required. I think not. For me, it's a tremendous convenience. So,
Do clients like having both of you?
do the clients object? Very occasionally, I do have clients who say, "Why is she in the room?" And I say, "That's because how we do it." They say, "Well, I don't want to talk with her here." And then she leaves. Usually it's something about abuse or something like that. That's what is there. Maybe not. There he is. Hello, Avram.
Hi, Terry.
I am in Florida, Naples, Florida, and we're at
Okay.
a conference of addiction professionals. I'm going to turn the camera around so that you can see them. Not sure how-
Terry, you mean a lot of addiction professionals.
Yes, sir. Okay. Avram started this company basically from scratch. He's a specialist in addiction psychiatry with national credentials, and he started this company and made it happen. While they're thinking about questions, Avram, let me ask you, what were the primary barriers to success that you faced right at the beginning?
So even though it was only, about 8 years ago, at that time, there were several barriers. One is that equipment at the time, believe it or not, was prohibitively expensive. People would take just to set up one telemedicine unit with good high quality could be between $10,000 and $20,000. So that was one barrier. The other barrier was that in general, people who do this kind of work like to be around other people. And a lot of people, when you say you're going to do telemedicine, teleddiction work, telepsychiatry, they have an aversion, even though the facts may be otherwise, to doing this kind of service, that somehow it won't have the same effectiveness, that somehow you can't do the same observation that you could do in person. And also, as with all telemedicine, fears that you can't do the medical as you need to do. So you won't be able to see end-gaze nystagmus, for example, via television like you could if you were in person. Probably the other largest barrier was, at the time, good telemedicine networks were very difficult to come by. People did not yet know how to set up fast telemedicine networks with good bandwidth, so that you got good audio and video reception. And probably the last barrier was reimbursement. And if anything has changed the most in the last 7 or 8 years, it's the fact that everybody wants to reimburse for telemedicine now.
Okay, let's see if there's a question. Dave, can you help me? See anybody?
Yes, we have.
Well, go ahead and ask it. How did services get reimbursed?
So it's a very strange day now when we do not find an insurance company that will pay for a service done via telemedicine. Basically, they have learned that access, which obviously in this accountable care era and also in triple aim of medicine, access is extremely important. Good access also invariably saves money. And so I don't know of a single insurance company right now that isn't falling over themselves to reimburse for telemedicine. And the way you know this is true is that virtually every insurance company in the United States is madly trying to develop their own internal telemedicine programs inside those insurance companies. So it's a good indication of the fact that they're willing to pay.
Medicaid?
Absolutely. Absolutely.
Go ahead.
We have no problem collecting from managed Medicaid or state Medicaid.
Does he incentivize for self-pay, like making payment cheaper or more affordable for folks?
I didn't understand it. Say it again.
Does he make it more affordable for self-pay? Like, what is something that would be an advantage to the end user, or obviously the patient?
So your question was about self-pay?
Oh, self-pay?
I'm having trouble understanding the question, hearing it even because of the...
Terry, is the question about self-pay and sort of direct-to-consumer in-home care?
Yes.
That'll do fine.
Okay. So obviously, one of the biggest changes in telemedicine is direct-to-consumer. They call it DTC. This is a very controversial area. Many medical boards are fighting this. You probably have heard of services such as Doctors on Demand or Teledoc that provide services via an application on your phone, either iPhone or Android. And there's a lot of grave concern about this. And the only thing I can tell you is while the medical community is gravely concerned about doing medicine that way, insurance companies are as quickly as employers as quickly as possible are taking up these services as a way of saving money so that their folks don't miss work, their folks don't go to an emergency departments if they don't need to. And they see them as a big cost savings for their employees. So there's a kind of epic battle going on here about what to do about self-pay. If you do self-pay and you want to see a consumer at home, your biggest concerns would be around primary identification. So you'd have to have a way of confirming that the person that you're doing the service with is who they say they are. And then usually, if you're not one of the telemedicine agencies approved by an insurance company, you have to take an extra step to let the, if you're paneled on an insurance company, to let them know that you want to do in-home direct-to-consumer care.
Did we lose the video feed here? There we go. Avram, what about the cost? Can you have a self-pay patient, doesn't want to go through their insurance company, doesn't want anybody to know about it, high-profile person, they just want to pay cash? Does that happen?
Absolutely, it does happen. There's no question. You can establish a therapeutic relationship. If you do that, you want to do it and document why you don't have to have an initial face-to-face physical exam. Always important if you're going to do it that way. And there is an increasing business, especially amongst executives, obviously, and important company employees who cannot just be let go and easily rehire somebody else to do high-level addiction and mental health care via telemedicine. There's no question that that's ever expanding. We don't know what the numbers are because those things aren't typically, there's no reporting to any source. But we know that more and more people are doing it. EAP companies are increasingly looking for doctors and therapists who can carry out work in the home for their employees under EAP programs.
Tell us about detox and the Burke Center in particular.
Okay, so there were a lot of questions about whether detox could be done using telemedicine. And I think the answer to why it's successful in what we do is the same reason it's successful at any location. It has to do with very rigid protocols endorsed by all parties involved in carrying out the detox. Probably the one sticking point on this has to do with the ability to use Suboxone through telemedicine. And there are some questions about that, but as long as we have found, as long as we use the same detox protocols that we would use if we were there in person, there's little difference between us having to be there to see them first or not. A lot of that has to do with working closely with nursing staff on the other end to document any signs or symptoms that we feel we may not be able to get through telemedicine. But so far, protocol's working extremely well. In 6 years of detoxing in an outpatient psychiatric emergency center, we've only had one patient who advanced to the point where their withdrawal symptoms from alcohol could not be managed through telemedicine.
Give us some of your personal experience doing the running detox.
Sure. So detox is an interesting thing because 70% of our psychiatric patients who we see are dual disordered. And of course, days it's pretty difficult to not be able to treat both things at the same time in many cases. Usually, because the equipment is so good these days, we can do every assessment that we need to do for somebody in withdrawal that we would do if we were in person. Nurses are trained on the other end to carry out all the vital signs measurement. We use standard protocols, CEWA, opioid withdrawal, any protocol that would be standard that you would use, we use. And in the beginning, we had, in telemedicine, we thought we had to have the nurses check patients much more frequently. But in truth, if you think about how most detox is done, the doctor isn't just sitting there in the nurse's station all day waiting for something to go wrong. So in many ways, using telemedicine, we find that we're more reachable than doctors who are just reachable if you call their office and try to find them, because we can literally be found within seconds at any time by using telemedicine. So I've been very pleased with what we've done. We have knocked down 92% of people that used to have to stay in emergency departments where they would be detox can now come in an outpatient setting to be detox. So I think to me, that's been the most effective use of this, is to keep out of the highest intensive using most costly services like inpatient or emergency departments for these people to get their care.
Tell me about getting a new doctor up to speed.
So one of the hard things about getting new doctors up to speed, you mean in detox or in telemedicine?
Anything,
Or both?
Yeah.
So the best thing about getting doctors to be up to speed is to understand that their ability to form a relationship with the patient is exactly the same through the television as it is in person. Sometimes people get sloppy. TV magnifies anything that you do that isn't paying attention, isn't making good eye contact in any way, shape, or form, is easily picked up on. And so getting doctors to use their equipment correctly, make good eye contact through telemedicine, not bury themselves all the time in their electronic medical record, and stay in good contact with the patient is probably the hardest part of bringing people up to speed to use telemedicine. That, and that if they're working in their bedroom, they can't have their bed unmade and people cannot traipse through, and they have to use double security in their houses to be able to lock and make sure that nobody else will be able to hear or see what they're doing.
Have you had physicians you had to say, I'm sorry, this is not for you?
So about 10% of folks who get started eventually say this is not for me. The reasons differ. In general, the urge back around people face to face is very strong, and they want to return to that kind of relationship. To do telemedicine full time, you have to understand that you're improving access, and the miracle, the fun of it, is getting to all the people who ordinarily would not get to see a specialist in addiction medicine, because of access, because of numbers of specialists that are available. And when I work, I get the craving sometimes to see people face to face and wonder why I'm staring at a camera and a television. But I know all the time that I'm getting to people who otherwise wouldn't get care. So for that 10% that leave, I think that's one of the things that never quite get to them. So the importance of that, or the wonder of being able to do this, is not stronger than their need to see people in person.
Question? Please. The question was, they run a treatment program in a rural area, and they're interested in expanding services, not just medical, but also non-medical treatment services like counseling, group therapy, intake, assessment, aftercare. Do you have experience doing any of this that are non-medical?
Sure. There's a lot of research on basically every type of environment for the use of telemedicine that you can imagine. It's getting more and more routine for full intakes to be done this way, for serving people in intensive outpatient programs, in day treatment programs. So, you can set up a fully virtual network to do your services. And again, I would encourage you to understand that while it might not be ideal or it might not be your first choice, if that's how you can get access to people in rural areas, then that's the way you do it. And nobody's going to fight you on it or give you grief about it, because again, it has to do with access first. So you can do an amazing number of things in rural areas to really do a full treatment system using telemedicine. There are projects now that are going on with complete virtual treatment in many aspects of medicine. So not something that anybody should fear. And you can deliver virtually any kind of counseling service. If you look in the literature, you'll find that group therapy, individual therapy, various types of cognitive behavioral therapies. There's even a psychiatrist that I know that does psychoanalysis over telemedicine. So if a psychoanalyst is willing to do it, you know something's working. So I would encourage anybody to not shy from any aspect of implementing an entire treatment program only using telemedicine.
Okay, last question for Abram about the rate of reimbursement. I don't know if you know the answer to it, but how does it compare with face-to-face?
So there isn't any way in which you're going to get paid less than face-to-face. And you're going to find many insurance companies are actually going to be offering to pay you more, or you can ask for more, because again, this is a matter of access to them. The more access, the more treatment, the less for all costs they're gonna. So we don't have any, the rates are the same or higher. In many cases, if an insurance company or a authority wants to pay you, and you need somebody on the other end, and they are interested in having somebody there, so you need a nurse to do certain physical tests for you on the other end, you can also negotiate for a rate for the nurse getting paid. So you shouldn't be afraid to ask in any way to get paid well or to get paid for any ancillary people that you need in order to do your telemedicine job.
Question over there. So we know about the licensure. The question was really about the insurance company. Does the doctor providing the service have to be approved by the insurance company, or is it just being part of JSA enough?
Oh no, if you want to provide telemedicine as an individual person who wants to practice out of your office, you just anybody to get paid.
So one thing is, when we start a new service provider, we all have to get credentialed at that service provider.
That is true. If you're going to work for another service provider, and you have two choices when you serve clients, right? You can go through insurance, you cannot go through insurance. But in telemedicine, you can actually do it a third way, which is you can credential and privilege with the organization that you're working for. You sign a contract for how much you're getting paid, and that organization collects bills and collects on your behalf, so they get paid.
But the clinician then doesn't have to get approved, each one of them, by the insurance company, or he does?
So each organization, as part of credentialing, is going to submit to the insurance company their location for approval. But you don't have to submit the entire packet if you're working for another company.
So if you have 15 companies that are out there that you work with, because your clients are diverse and they have different plans, that clinician has to be licensed or approved by all 15 companies, correct?
Credentialed, I think is the word you're looking for.
Credentialed.
So
Yeah.
when a new hospital system comes on board, then the staff at JSA gets credentials every one of the doctors who's going to provide services for that new facility.
At that location. Yes, at that facility. That's correct.
We've got two, I think last time I looked, 2 full-time people just doing credentialing.
Yes, but there are some things that are changing as an advantage. Joint Commission, which we are joint accredited, now allows an institution that is also Joint Commission accredited to accept the other organizations accrediting. So if we credential all of our docs, if we go to an institution that is Joint Commission accredited, they can just accept our credentialing process without having to go through their own, which has really revolutionized how quickly we can get started at locations.
Okay, I want to get Will on the line here. Abram, is there anything last thing you want to tell a group?
No, I really encourage you all to explore this modality. I have to tell you, if you think patients act different or will do things differently because they're on TV, you're absolutely wrong. Patients are exactly the same, and taking care of them is the same. And in many cases, because people know that they're getting something special, like ordinarily they couldn't see a specialist, but through this they can, you'd be surprised how much they appreciate that, and they understand that they're getting to see a specialist and it's something special. So I encourage you all to give it a try, and I wish you all the best of luck.
Thank you, Abram, very much for your time.
Bye-bye.
Let's see if this.
Hello.
Hello, Will.
Hi, how are you?
I'm just fine. I'm playing with a webcam here. I'm going to show you the group here. This is Will Yancey. He's our director of IT. And Will, we've got about 5 minutes to see if people have some questions you want to ask the IT director.
Sure.
David, why don't you start off by asking a question that's IT related? Help me out here. Will, tell us about bandwidth at the clinics.
Okay, bandwidth at the clinics. One of the things that we prefer the clinics to do is to have a minimum of 1 gig up and 1 down. 1 meg up, 1 meg down. I've recently changed the requirements that we would like, make it 2 and 2, and have a dedicated line. A lot of hospitals and clinics, they share bandwidth, but we prefer that the video has a dedicated line or dedicated amount of bandwidth so that it'll give a good video conference.
What would you say to somebody who says, I don't really need an IT guy, I think I can do this on my own?
After you consult with your IT guy, then you could. You definitely need IT in order to for it to be done. Once it's set up, it's a pretty simple to do and maintain. But you definitely need an IT person to do it because it takes a lot of the way. And one of the things that we like is for the technology to be invisible, and I think you would need an IT person to make sure that happens.
Yeah, I have a question. Does the platform support saving and reviewing sessions later?
Well, due to the HIPAA requirements, we're not allowed to record any of the sessions. The platform does have that capability, but we don't have it turned on with our systems.
Just shifting gears a little, getting away from actually telemedicine. Would this be something that could be used as an instrument for an intake process for assessment to go into a treatment facility, much less the way, almost like chat rooms are trying to be used on websites, so that this could be an initial pre-admission assessment count session?
So the question is, would this lend itself to doing a pre-admission or an intake at a treatment center or perhaps even a physician's office?
Most definitely.
Yeah, somebody is in Moose Jaw, Montana, and you want to do an intake session.
Oh, most definitely. Actually, we have here at JSA, we have physicians all over the world. We have one in Spain, Saudi Arabia, a few in England, Israel as well. So, and they see patients in Lufkin, Texas, or in Dallas, Texas. So we can have doctors anywhere as long as they're licensed to see patients at intake facilities, at hospitals, and emergency centers, or even at a physician's office.
Well, what about with their iPad somewhere where there isn't any facility?
That is possible, but that's not the process that we use. We do have where the iPad as a backup, so that if there's a client that needs, our patient needs to be seen, then we can set up we can set an account to where they can actually take the iPad into the patient, even on a Surface or an iPad, and actually take it to the client if that client can't move, or it's bedroom, or reason why that client can't go into the office. A lot of the mobile crisis teams have iPads with them where they actually go to the clients.
Okay. I think we have time for one more question, then we're done. Okay, questions coming here, Will.
Okay.
Will, did it take you a while to get up to speed?
I don't think it did, because it's a passion of mine. I actually like doing this. And it's once you do it for a while, I've been in IT for almost 20 years. So it's the video conferencing piece, the back end part of it, the server pieces for to house this, the platform and the infrastructure, all of that was pretty intriguing to me. So for me, no. And I think it's even for physicians or executives, those that want to, it's pretty simple once you learn it.
Last question.
About 20 years ago, eGet Going, which was then part of CRC Corporation, created group therapy through telemedicine. And in this, everybody could see the therapist, and the therapist could see everybody in the group, but nobody in the group could see any other patient in the group. Do you know if any of that is going on now?
Yeah, I can answer that. There is software that'll do that, where you can have people in the group, and you can we used it at the university, where you can control who sees whom, and then they can raise there's a little icon for when they raise their hand, so you don't have everybody talking at the same time, and you can give control of the session to somebody else, and you can take it back. That software is available, yes.
Yes, it is. That's correct.
Okay, go ahead. Just sing it out. So the question, we've had a few glitches here. We've had some bandwidth issues, connectivity issues. Actually, today went pretty smoothly. I'm pretty pleased with how smoothly it went. Yes, you will have glitches like all the time. You saw sometime we were talking to Avram, it kind of froze up a little bit. That's because we've got 5.6 megabytes per second service here. At home, I have 125.
Right.
What do you have there at the office, Will? What's your bandwidth?
I'm running 280.
So you don't have that. We got 5 here at the hotel. The free service here is 2 megabits per second. So that's part of it, right?
There's most definitely. That goes back to the first question where bandwidth does matter. And that's one of the reasons we asked the clients on the other end to have a dedicated line for bandwidth.
Okay, Will, I'm going to let you go. Thank you very much for helping us out here.
Thank you. Bye-bye.
Now, so I'm going to answer that last question here. First, I'm going to close this off. You do it like this. Go down here. It's supposed to let me close it. Did you notice when Avram was talking, he picked up a little marker or something, was fiddling with it? Yeah? So that goes to my comment about little habits are much more obvious and can be distracting. That wasn't planned, but it was kind of cute. So in conclusion, let me just say, telemedicine and telepsychiatry, telehealth has a lot of potential, a lot of advantages that people can utilize, and it's only limited by your imagination and your creativity to how you're going to be able to use this modality for your own programs.